All right, guys, so this will be the intubation portion of your lab midterm. I'm not going to go over like the introduction and the gathering your equipment. That's pretty self-explanatory. So you will, yes, you'll come in, knock, knock, introduce yourself. So, hi, I'm Lauren. I'm from respiratory. I'm washing my hands, putting on gloves. I'm going to have vitals up on the monitor here. So I'm going to give you a paper chart where you will write down the heart rate, the respiratory rate, their SpO2, and then you're going to listen to breath sounds. So make sure again that you have your stethoscope when you do your midterm, and you're going to auscultate at least those 4 checkpoints. Then you're going to gather all your equipment. Once you've gathered everything that you think you need, you're going to check it to make sure it's functioning. So we're going to be checking to make sure, again, that our blade has a working light. You can use the old school blade if you want, or you can use the glide scope. It is your preference. Obviously, if you're using the glide scope, you still need to make sure that the light on the end of your scope is functioning and that your camera is functioning. You're gonna check to make sure that your cuff is, good on your tube. And then once you've done that and you think you're ready, you'll let me know and you'll move on to the actual intubation portion of it. So one thing I forgot to show you guys, when you check your cuff, after you deflate it, you can keep your syringe attached to your pilot balloon. So again, we use a luer locking syringe, not the slip tip, luer locking, so you can lock it on. And then it's like primed and ready to go. So as soon as you get your tube in, you can just push your air in and then pop off your syringe after you remove your stylet. Okay, so let me get this ready. So again, you're gonna have a partner, but your partner is just there as an assistant. They're not the one being graded. It's only the person that's intubating that's being graded. So once you've checked your equipment, you've got everything gathered up, you're going to place a cannula on the patient. The OPAs, the MPAs, you do not have to insert those. Those are just equipment that you should have on hand in real life in case you do need it, but you will not be actually doing it on this. Just the cannula part you will actually put on your patient. You will hook up your suction. So I'll have the suction canister on the wall, but you will have to put the suction line or plug it in and grab your yonker. So this is a yonker or yonkauer, however you want to pronounce it. So this is for your oral suction. So again, in real life, a lot of times when we intubate, patients have a lot of oral secretions. They might have blood, vomit, tons of mucus, any of the above. So we always have suction on hand so we can clear our airway and clear our field of view. And you'll turn on the suction. So get familiar with your suction regulator on the wall. You turn it onto the reg or portion of the pregnancy brain. But to check your suction pressures, so when you flip it on, you occlude the end of your suction tubing. You can also occlude the tip of the yonkauer. I just prefer to do the tubing, but no way is right or wrong. And then you look at your pressures, your suction pressures, and you should be about 100 to 120 for your suction pressures. So that'll be part of your equipment gathering, equipment check portion of your midterm. Okay, so then when you again have all that gathered, you're going to move on to the next step, which is the actual intubation part. So the intubator, so me, I'm gonna make sure that my patient is in the nice sniffing position. I actually prefer to not have a pillow under my patient because again, that's gonna kind of push their head forward a little bit. We want them more sniffing. So I'm gonna remove this pillow. And then this is gonna be a little challenging because I'm doing it by myself, but I'm gonna have my assistant pre-oxygenate my patient. So again, you as the intubator need to verbalize what you want your assistant to do. So you can tell them like pre-oxygenate my patient, again we're just verbalizing, but say for the 1 to 3 minutes, or until we at least have a SAT of 99% or 100%. So you're gonna have your assistant pre-oxygenate your patient. So for a bag, remember we do 1 squeeze every 6 seconds. So it's breathe 2, 3, 4, 5, 6. Breathe 2, 3, 4, 5, 6. And when we hold our bag, we do our CE clamp. So your C goes around the actual mask, and then your E, or your other fingers, goes underneath their jaw and lifts their jaw up and forward. So you have your CE clamp on your bag. You're not gonna be great on that, but that's just for your guys' reference. All right, and then once you think you're ready to go as your intubator, again, make sure they're in that nice sniffing position. Get your stuff ready. And then you're gonna go in. Oh, in addition to all of your equipment stuff, make sure that this bed is raised up at the appropriate level for your height. So again, you want it kind of navel height. This is as high as it goes. So for taller people, you might have to bend over a little bit, but you do not want the bed super down low. You don't want to have to bend over. You want to try and have your field of view up to, bring it up to you. So I'm gonna go slower than the 10 seconds required because I'm gonna explain things as I go, but remember, once you stick your blade into your patient's mouth, that's when your timer starts. If you don't get your blade or your tube in within 10 seconds, you need to pull your blade out, have your assistant rebag your patient or reoxygenate them, and then you can try again. So if you're using the old school blade, remember that this part of your blade is your field of view. So we do not stick our tube down this little channel. Otherwise you'll lose your sight of your cords. So once your blade is in, we go from the corner of the mouth and kind of go in sideways a little bit, if that makes sense. And then I'm going to show you guys the difference here in a second between a Miller and a Mac blade on the glide scope. But for the intubation part, so I'm going to stick my blade in. Again, remember you want your thumb on the handle of the blade. I like to hold my handle or my blade down low, so I'm not holding it way up here. I have it down here. Like, it gives you better control over your blade. So with a Mac blade, the tip of your blade goes into the little notch above your epiglottis. So it's gonna lift the epiglottis up by you pulling up, versus your Miller blade, it goes underneath the epiglottis and lifts the whole epiglottis up with the blade. And again, I'm gonna show you that on the glide scope here in a sec. All right, so when you guys do this, again, when you stick your blade in, I don't want you to just be looking up here and just blindly shoving your tube in. That is not appropriate intubation. That is how you could potentially cause a ton of trauma to your patient's airway. So once you get your blade in, you need to get down at their level. So you gotta bend down a little bit still. You just shouldn't be completely bent in half. So when you get your blade in, again, we're also not rocking back on our patient's upper lip. That's how we cause trauma to the upper lip, break teeth. That's a bad thing to do. So you get your blade in, we're gonna pull up. So you almost imagine you're kind of trying to lift your patient's head up off the table. So up and forward a little bit. Get a good sight of your cords, and then again, we come in from the side. Stick your tube in, pull out your blade. Always close your blade. These can, if they get hot enough, especially if they're the old school light bulb, they can catch your linens on fire. The fiber optic ones don't really do that, but it's just good practice. You always close your blade. You're gonna pull your stylet, inflate your balloon, and then your assistant is gonna pull the mask off, put the end tidal CO2, because remember that's another thing that you need to grab. So most likely your colorimetric one, which, sorry, I forgot to grab that, but you're gonna put your colorimetric end tidal on the end of your tube, and then this will fit sideways on it. It kind of creates like a little L shape. But for this, I'm just gonna throw it on. And then as your assistant bags your patient, I'm gonna look, and you're gonna look for bilateral chest rise, and you're also gonna auscultate your 4 points again. When you intubate, this is the only time when you don't follow the one breath every 6 seconds, because you need to make sure that tube is in the right spot quickly and that you're not just pumping a bunch of air into their lungs. So it's gonna be squeeze, 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 squeeze. So you can check all those 4 points quickly and to know if you're in the right tube. I don't know how well you guys can see it. Let me lower this down. But I have bilateral chest rise, and again, if I had a stethoscope, I would listen. Okay, so let me get the glide scope going. Okay, this is gonna be a little bit of a challenge, so you guys can see it and I can maybe see it. Let me get in there really quick and then I'll move it. Okay, so you guys see on here, this little U-shaped looking dude, that's the epiglottis. So if I go slightly above, this notch here, that's where your blade sits for a Mac blade. The Miller blade will actually go underneath your epiglottis and lift that whole structure up. So I'm gonna get into the correct position because my blade's a little too high. Again, I'm not gonna rock back on their mouth. I'm gonna pull up and forward, and I don't know how well you guys can see it on this screen, but there's my cords, those nice little white V. These guys, I will give you a hint on these mannequins, you really have to the more you pull up, the better on them. So get my tube in, pull out, inflate my cuff, bilateral chest rise. And that's the end of it. So once you see that you have bilateral chest rise and you can hear equal breath sounds, you're good to go. If you get your tube in, or you think you got your tube in, and then you end up, inflating your cuff, pulling your stylet, doing all that, and then you don't get bilateral chest rise, you do have another attempt. I'm gonna give you up to 3 attempts. So if for some reason you do intubate the esophagus, you can